All right. This is week two, MedSurge 2. We're going to talk about coronary artery diseases, MI, heart failure, and end it off with thrombocytopenia. Uh, we're going to go as in depth as possible, and we're going to have hopefully, some question problems depending on if I encounter technical difficulties. This is our first time doing this, so we'll see how this plans out. Uh, we're gonna follow the same structure as we did in lecture. So we're gonna start with CAD and then MI and cover anginas, and then heart failure and end with thrombos. So let's start off with just a few things to recap. So bad cholesterol, good cholesterol, which one is it? So LDL is going to be bad cholesterol. HDL is our good cholesterol. LDL, you take the L, right? So bad cholesterol is L, okay? You want to lower LDL. So L and lower LDL, okay? So when you have an increase in LDL, right, you're going to encounter some atherosclerosis, right? So it's going to increase your risk for atherosclerosis, which is the hardening of the blood vessels. So this is where you have these pieces of fat running around in your arteries, and then over time they just get deposited, right? And they start off as these little fat streaks in your arteries. Over time, these build up, turn into clots. Those clots are going to burst, right? They increase your risk for MI, embolisms, so on and so forth, right? But overall, they harden the artery, and that's called atherosclerosis, okay? As with anything, these have risk factors. So we have risk factors for atherosclerosis. Okay, so with risk factors, you can't even see that. Shoot. You have modifiable and non-modifiable. Okay, so and the treatment plan is going to depend on how many risk factors that you have. Okay, so this is eventually something that can progress to coronary artery disease. So when atherosclerosis progresses, these arteries harden, you get coronary artery disease. Uh, so that's going to end up being a progressive disease. It's going to have collateral circulation, right? That's going to be caused. So collateral circulation is what's going to happen with, one second. So coronary artery disease is a progressive disease. So it's not like you start off with just hardened arteries, right, since day one. So this is something that happens over time. You have poor diet, sedentary lifestyle, more and more risk factors are going to add up throughout your life, and then you're going to end up with coronary artery disease. So coronary, it's progressive. Okay. So what's going to happen with a lot of these diseases that we're going to talk about today? They're going to be a result of your body's attempt to adapt, right? So your body's going to encounter the stressor, it's going to try to compensate, it's going to try to adapt. Ultimately, it's going to die trying. So these adaptations that your body's going to face can save you, I don't know, it's going to keep you going for 10 years, 15, 20 years. Eventually, these adaptations are going to give out on you, right? So one of these adaptations when you have CAD is your body's going to create peripheral circulation. So normally you have this one blood vessel, okay? It becomes occluded. These clots start to fill up. So your body's going to try to go around the clot and it's going to form these extra blood vessels around it, okay? So that's going to be called collateral circulation, okay? So that's just something to look out for when somebody has CAD is it's going to create these small veins around the occlusion to try to get around it. So let's go back to risk factors. So you have two categories. You have modifiable and non-modifiable. This is self-explanatory, right? Non-modifiable stuff that you can't modify, things that you're stuck with. So age, right? So more likely to have it as you get older. Gender. So gender is one of those where men are going to have a greater risk for coronary artery disease than women. However, after menopause, women and men are almost equal. Ethnicity, so Caucasian men, more likely to have coronary artery disease. And if you have a family history of CAD, you're more likely to get it as well. So non-modifiable is going to revolve around you and your family, who you are, who your family is, right? Modifiable. So these are things that you can change, and this is typically where treatment begins. So again, since it is something that's progressive, you're going to go into your doctor's office. Let's say you're a Caucasian male, aged 50. You're going to go into your doctor's office, and he's going to tell you, hey, listen, your LDL is very high, your blood pressure is high. Let's start with these treatment plans that are revolving around your modifiable risk factors, right? So they're going to start with your diet, okay? They're going to talk about your elevated serum lipids, your hypertension, tobacco use, your physical activity, diabetes, obesity, substance abuse. So again, that methamphetamine, and depression, right? So these things are going to affect your risk for developing coronary artery disease. The thing about meth, users of meth are going to have meth mouth, so they eat a bunch of sweets and sugars, and of course that ties in with your poor diet, right? So these drugs that you're going to use and abuse are going to increase your risk of coronary artery disease. So believe it or not, alcohol in moderation is not a risk factor for coronary artery disease. Okay. So if alcohol comes up on your exam, but it says alcohol in moderation, that's not going to be a risk factor. Cool. So you have, again, treatment is going to start with your modifiable. Okay. So one more time, this is going to be like diet. They're going to ask you to go on a DASH diet, right? A dietary approach to stop hypertension. So they're going to ask you to lower your sodium intake, lower added sugar, all that good stuff, right? Then they're going to tell you to quit smoking. They're going to tell you to increase your physical activity, lower your BMI. Okay. Let's go back to that collateral circulation concept. So these new connections are going to appear within your coronary circulation. They increase with chronic ischemia. So this goes back to the adaptation that we were talking about earlier. So you have chronic ischemia. So ischemia is your lack of oxygenation, right? So oxygen has been cut off. It's been cut off for a while. So your body says, okay, I need a new way to pass this blood around. I need new ways to get oxygen. It's going to start developing these arterial and that's a long word, anastomosis. Okay, so these new connections, these arterial anastomoses, are the connections that it's going to create. However, these are new connections, right? They're not the ones that your body is typically supposed to run with. So they're probably going to be inadequate for dealing with long-term coronary artery disease or with rapid onset CAD. Okay, so again, these adaptations aren't sufficient to last you a lifetime. They're just like little short fixes that your body can come up with to solve the problem in that moment. Okay. So for management of CAD, you're going to have prevention, right? So prevention is the number one intervention that we're going to go with, primary intervention. So it's going to manage your risk factors, regular physical activity program. The diet should limit saturated fats and increase complex carbs. Okay, so lower your fats, increase your complex carbs. And you're going to do a complete lipid profile and guidelines that recommend statins. Okay, so start with always primary prevention is going to be preventing the disease in the first place. Okay, then you're going to move to your drugs. Okay, drugs to know are going to be your statin, your niacin, your fibric acid derivatives, bile acid sequestrants, and PCSK9 inhibitors. Okay, let's talk about statins for a minute. Keep in mind also antiplatelet therapy. So things like aspirin, low dose aspirin, that's a blood thinner, right? So if I want blood to have an easier access through your occlusions of fat, right, and the plaques that are deposited in your arteries, I'm going to thin the blood, right? It sort of makes sense. Yeah, so that's why we'd give aspirin. So statins, right? So for statins, so this is stuff like atorvastatin, so Lipitor. These are going to inhibit cholesterol synthesis. They're going to decrease LDL. and increase HDL. This is what we want, right? Remember, LDL is the fat, the bad fat, the bad cholesterol that we don't want in your arteries. So decrease LDL, increase HDL. That's good. That's what we want. However, you're going to monitor for liver damage and myopathy. Okay, so this is very heavy on the liver. So we are going to want to do LFT, so liver function test. Um, it's going to cause myopathy, hepatotoxicity, and GI side effects. Okay, so again, that's weakness, fatigue, fever, dark colored urine, anything that you'd associate with hepatotoxicity. Think of that when you think of statins. Okay, plaque disruption. So the drugs that we can give to stop platelet aggregation, so that's aspirin. Um, and the side effects of aspirin are angioedema and dry cough. So if you have angioedema or dry cough, you're going to report that. Um, let's see. Hmm. Yeah, so we're only going to start moving to drugs once diet and exercise are ineffective, or if you're already progressed far down the line. Let's say it's no longer a 50-year-old white male, it's a 60-year-old white male, their condition's getting pretty bad, then we're going to move them onto the atorvastatin or Lipitor right away, right? Atorvastatin, simvastatin, and rosuvastatin, right? So Crestor and Zocor as well. So Lipitor, Zocor, Crestor. Okay. Niacin is going to lower the LDL and triglyceride by inhibiting the synthesis of it. So it's going to prevent your body from creating LDL and triglycerides. So it stops it at the source. And then it's going to increase your HDL as well. So watch out for flushing, pruritus, and GI side effects. Also orthostatic hypotension, sorry. Let's see. Let's cover bile acid sequestrants. So bile acid sequesters lower your LDL, but the common side effect is GI issues, right? So give this 2 hours before your other meds. We don't want them vomiting. We don't want them having diarrhea, nausea, all that good stuff. So if you're going to give bile acid sequestrants, give it 2 hours before other meds. And it increases the conversion of cholesterol into bile, right? Bile acids. Moving on to meds for hyperlipidemia. So HMG-CoA reduces inhibitors, reductase inhibitors. It slows the production, but it's the most effective. So again, back to your statins. Let's see. And then you have other treatments of CAD. So aggressive treatment of hypertension and hyperlipidemia, encourage the planned program for physical activity. So it's 3 to 5 days a week, at least 30 minutes per day. So if you have 30 minutes a day, 5 days a week, 150 minutes of exercise. This also involves the healthy diet, smoking cessation. So that covers CAD for now. We might go over the surgical interventions like CABG, coronary artery bypass surgery, all that good stuff. Let's talk about angina. All right, so angina is chest pain. Okay, so this can manifest as chest pain, dyspnea, diaphoresis, so sweating, anxiety, all that good stuff, right? So this is a lot of people think that they're having might be having a heart attack. Sometimes it could just be this chest pain, which a lot of times is uh, um, a sign of heart attack, right? So you have different types of angina, okay? So angina is going to be caused by a increased demand of oxygen or a decreased supply of oxygen. So it's going to be caused by a bout of ischemia, okay? So anytime your heart's running out of oxygen, your tissues need it, you're going to feel that chest pain, okay? That's your heart telling you like, hey, we need some oxygen right now. I'm using too much of it. We don't have much left. secreting too much lactic acid. Okay, your anaerobic respiration is getting too high. We need some oxygen. Okay. So the most common reason for angina to develop is narrowing of one or more arteries by atherosclerosis. Now you're starting to see how this whole picture ties in, right? So I live an unhealthy lifestyle. I have all of these risk factors. I smoke, I eat junk food, I sit on my butt all day. Now I have plaque in my arteries. Um, my arteries are no longer efficient at carrying blood, so I try to compensate by creating these new columns. These columns aren't that strong. I try running, I can't. I try changing my diet. I try increasing my whole grains and lowering my saturated fat. It's not working that well. Now all of a sudden I start getting this chest pain. I start developing angina, right? Now, what kind of angina? Let's get into that. So you have chronic stable angina. Okay, so stable, I like to think of it when it's stable when I'm stable. Okay, so if I'm chilling, I'm sitting down right here, no chest pain. Okay, so um, the pain doesn't last long. It's only a few minutes. Okay, so the oxygen supply and demand is mismatched. I'm sitting down though, so my oxygen demand isn't that high. But as soon as I get up and I go try to walk up the stairs, I try going for a walk. Excuse me. I try going for a walk. The angina is gonna pick right up, right? My body's telling me, "Whoa, buddy, we don't have the supply for this, so you better sit back down," right? So it's gonna give me that chest pain. So it's provoked by exertion or stress. This is stable angina. Okay. On an ECG, right? If I take an EKG, the T wave is going to be inverted. Okay. So that's going to be a sign of my angina. So how are we going to treat this? Okay. What's the problem? At the end of the day, how we treat it is by focusing at the problem. Why am I getting this chest pain? I don't have enough oxygen. My oxygen demand is high. So I need to lower my demand. I'm going to take a seat. Okay. One hallmark of stable angina is it disappears when I'm resting. Okay. It's a game of supply and demand in terms of oxygen. Okay. So if I sit down, I'm no longer needing enough oxygen to power all my muscles. I'm not producing lactic acid anymore or as much of it. My angina is going to go away. Okay. Also nitro, right? Nitroglycerin is a vasodilator. Okay. So another way that I can increase my oxygen supply, I'm gonna expand my veins, right? I expand my veins. That means whatever plaque, whatever stuff is limiting my blood flow is now, well, not limiting as much anymore, right? So my veins are more dilated. I'm allowing for more blood to pass through. I'm increasing my oxygen supply, and then I can keep on going around about my day, right? So that's stable angina. Okay, when I'm stable, my pain is stable, right? I don't have any. But when I start to move, I start to get that pain. Again, cured by rest and nitro. Now, stable's twin brother, unstable, right? So also crescendo angina. So unstable angina. So if stable goes away when I'm sitting down, unstable is not going to go away while I'm sitting down. Okay. I try to rest, I try to get rid of it, but there's still pain. Why is this? Okay. So unstable angina happens when I rupture my unstable plaque, exposing the thrombogenic surface. Okay. So so let's see if you guys can see this. No, let me get something where I can draw. One second. Okay, so right here we have our artery, we have our plaque made of LDL, and it's going to be covered, right? So it's going to trigger a immune response. It's going to cover your plaque right here. Over time, though, it's going to keep getting bigger and bigger. All of a sudden, this bursts. Okay. Oh, as soon as it bursts, oh, you're gonna feel it in your chest. I can't breathe. My chest is tight. It hurts. This, and that, and the other. So it's gonna rupture the unstable plaque, and it's going to expose the surface underneath right there, right? That's the thrombogenic surface. So it's going to be a new onset of angina. It's going to um, last greater than 10 minutes. It's going to occur at rest and while you're exerting yourself. Okay, so that's the difference between stable and unstable. If it's unstable, it's unpredictable. Um, Even when I'm sitting down, still gonna have that chest pain. Okay, more often and more severe. So you're gonna have less bouts of relief. It's gonna happen a lot. That rupture is gonna hurt and it's gonna hurt a lot. Okay, so this is gonna usually occur with ST depression. Okay, so you have your ST wave on your EKG. So P is your AFib. Okay, so atrial fibrillation, right? So P wave and then Q, R, S, T, right? So ST is going to drop. Okay, so normally a lot of us are familiar with ST elevated myocardial infarction. Okay, so STEMI, right? So when the ST is elevated, that's going to be not a sign of just ischemia. It's going to be a sign of tissue necrosis. Okay, so long-term ischemia is going to be caused by chronic lack of oxygen. Okay, so you have chronic. So let's go way back. Hypoxia, low oxygen. Okay, that's going to lead to that's going to lead to ischemia. Okay, which is going to lead to necrosis, tissue death. Okay. The way that I like to remember this is ST elevation, right? When you die, you ascend to heaven, right? ST elevation. Okay. So when you have ST elevation, you ascend to heaven. You're ST elevated. You have a heart attack. Okay. That tissue is dead, necrosis. The tissue died, went to heaven. ST elevation. This isn't that. Okay, this is ST depression, okay, which is going to happen before ST elevation. So we have the ST bar right here, and that's going to drop. That's going to tell us that there is active ischemia going on, okay? So that is going to tell us that there's some tissues that are about to become necrotic, some tissues that are not receiving enough oxygen right now, okay, because of the rupture of the plaque, okay? So that's going to tell us that we need to treat it immediately. We're going to treat it with rest, nitroglycerin, and drugs that affect platelets and revascularization, okay? So again, we're going to give you nitro. We're going to try to get as much oxygenated blood into that tissue as fast as possible, okay? Now let's go into the other unusual types of angina. So let's talk about variant angina, okay? I like to call it variant and vasospasm. You got both V's, variant, vasospasm. So this is the coronary vasospasm. So the muscle around your arteries are just gonna spasm out, right? They're gonna go ballistic, and that's gonna cause chest pain. Okay, so it's gonna bring you right back to angina. These occur at rest, and they may occur with or without the presence of coronary artery disease, right? So it doesn't matter which one you have. So this isn't a matter of blocking the artery, right? This is simply a muscular spasm that's going to cause pain, right? So what triggers it? Smoking can trigger it. Your environment and other substances, so histamines, epinephrine, cocaine, these are stimulants that are going to make your arteries go ballistic and give you that vasospasm angina. This is also called Prinzmetal's angina. Okay, so you have some V's and P's in there, right? So they could be variant angina, it can be vasospasm angina, or Prinzmetal's angina. Okay, so treatment. So we know that calcium plays a big role in muscular function. So what we're going to do is give you a calcium channel blocker. Okay, diltiazem, right? So that's going to decrease your vasospasm. So again, calcium channel blocker. Okay, We can also give long-acting nitrites alongside these calcium channel blockers. Okay, so we know calcium plays a role with muscle function. These muscles that are choking your arteries when they spasm, we need them to stop that. So we're going to give calcium channel blockers. Okay, this is going to lead us to our last form of angina, microvascular angina. This is going to be more common in women, triggered by doing your normal ADLs, so not at rest, and your treatment's going to be nitroglycerin and rest. Okay, so don't confuse this with unstable angina. Okay, this is going to be more common in women, just going about their normal life, exerting themselves, doing their ADLs. So how are we going to take care of that? Nitro and rest. You're going to find nitroglycerin is common in a lot of these treatments because it's going to dilate your veins, right? So it's going to allow for that blood to pass easier, pass a lot quicker. The only two that I would focus on that are really different is going to be Prinzmetal's angina, so the vasospasm angina, and unstable. Okay, so for unstable, remember keynotes, ST depression, okay, the rupture of the plaque, exposing the thrombogenic surface. It lasts longer than 10 minutes. It's not relieved by rest, okay? It happens while you're resting and while exerting yourself, and you're going to have nitro and deplatelet drugs, okay? Vasospasm, it's going to occur at rest, and you're going to go ahead and need calcium channel blockers. It can happen with or without coronary artery disease. And that's pretty much it in terms of angina. Okay, so what's going to be our plan of care? Again, this whole concept revolves around oxygen supply and oxygen demand. Okay, so we want to always increase oxygen supply to match or be greater than the demand. Okay, so all of our issues are going to revolve around not having enough oxygen reaching your tissues. Okay. So that's going to be our antiplatelets, our nitrates, which is the most common, our beta blockers, um, lipid lowering drug therapy, and ACE inhibitors. One thing to keep in mind about beta blockers is they are going to affect the heart rate. Okay, so the way that I like to remember um, beta blockers is, well, this is also going to revolve for alpha receptors as well. You have A, B, C, D. Okay, A and C go together, B and D go together. Okay, without AC, you're going to have a BD, a bad day. Okay, ACBD. Okay, alpha constricts and beta dilates. Okay, so let's focus on the BD. Okay, so you have beta 1 and beta 2. Beta 1 is going to act on the heart, and beta 2 is going to act on the lungs. You have two lungs, okay? So beta 2, lungs, beta 1, heart. Certain medications are going to act on both. These are beta non-specific, okay? Beta specific and beta non-specific. There's one question in the Kahoot that mentioned something about asthma, right? So it could interfere with a client's asthma if you give them a non-specific B2 inhibitor, okay? Or sorry, beta blocker, right? So this is a beta blocker, so it's going to slow your heart rate, okay? So when we slow your heart rate, remember the heart's a muscle, right? Which means it needs oxygen, okay? The more it functions, the more oxygen it needs. So we're going to lower O2 demand by lowering your heart rate, okay? This is another one of those things that you're going to hold your beta blocker if the heart rate is lower than 60, okay? So that's something you're just gonna wanna look out for, because remember, we don't only just treat the symptom. Your treatment is gonna encompass everything. So if I'm the nurse and I'm gonna administer my beta blocker and I see my patient's heart rate is 56, we're holding that med. We are holding that med. Okay. Um, It's going to reduce the demand of the heart. It works well for ventricular tachycardia. And if you're going to give an antiplatelet, so if I'm going to give heparin, it has a short half-life, needs to be shut down 30 minutes before going to the cath lab, right? If I have heparin and I'm sending you to the cath lab, you're going to bleed out and you're going to die, okay? So if I know my patient is going to go to the cath lab, which we'll talk about in a minute, we're going to shut down heparin 30 minutes before. And then you have long-acting nitrates, so it's going to reduce angina. Remember, this is your nitroglycerin, the most common. The ways that you can administer is oral, right? You can go like the sublingual route. You could go for the ointment. You could go for the transdermal patch, and you can do isosorbide dinitrate, right? So with nitro, this is something that comes up a lot in ATI. The side effect is going to be headache and orthostatic hypotension. Okay, that's something that they're going to try to trick you. A lot of the questions in ATI that I've seen about this are going to be like, the patient is taking the patch. Okay, the patient is currently taking the patch, but they're having bouts of angina. Okay, what method should they do? And it's going to be like, well, the patch clearly isn't working, so you're going to need to take the pill. Or they're going to try to throw you off and they're going to say, they're going to try to throw you off by saying something about the hypotension and the headache. Okay, so that's stuff to look out for. So why are they getting orthostatic hypotension? Okay, their veins are dilated. Sometimes the nitro does too good of a job. Okay, it does too good of a job. Your veins are all the way dilated. If I increase the area inside your vein, the pressure is going to decrease. So you're going to have hypotension. You're going to stand up and you're going to pass out, right? That's why I sit down when you take these medications. Let's talk about considerations for the beta blockers. We kind of already touched on this. So again, beta 1 receptors, you have one heart. Beta 1 is found in the heart. Beta 2, some are found in the blood vessels, lungs, and the liver. Okay. So we want cardioselective beta blockers because they only work on beta 1, right? So cardioselective. So this is going to be your LULs, your LOLs, right? The L's kind of look like ones, okay? So beta 1. So that's your atenolol and your metoprolol. These are your Lopressor and tenormin, other way around. Atenolol is tenormin, metoprolol is your Lopressor. Okay, so LOL is going to be our beta 1, cardioselective. Okay, some beta blockers are non-selective. They block beta 1 and beta 2. So that's going to be your nadolol and your propranolol. Both still end with LOL. So disregard my tip and trick. Some beta blockers block alpha 1, beta 1, and beta 2. That's your carvedilol and your labetalol. Okay. So if your patients are intolerant of beta blockers, you can use CCBs. Okay. So your LOLs, your beta blockers, your LOLs. I recommend knowing metoprolol, atenolol. Those are the ones I've seen a lot in patient charts and clinicals, so on and so forth. So you again, now we're going to look at our diagnostics for our chest pain, right? Client comes into the ED reporting chest pain, reporting angina. The first thing we're going to do, we're going to try to put them on a 12 lead EKG as soon as possible. Okay, you have 10 minutes to do this. So establish your vitals, get them on an EKG if you can within 10 minutes. Okay, we're going to go into this a little later, but you're going to realize that for STEMI, right, if you have ST elevated MI, you only have 90 minutes for treatment. If you have NSTEMI, you have a lot longer. Okay, so this is why we only have 10 minutes to get you on that EKG. We're also going to look at cardiac biomarkers. So this is going to be your myoglobin, your troponin, and your creatinine kinase. Okay. So these biomarkers are inside the cell for the most part, and they don't occur until there's already damage that's happening, right? So myoglobin is going to be your, if there's muscular damage, it's going to be released. Same thing with creatinine kinase. So we're going to stick to troponin I and troponin T. So they're going to take your echocardiogram. This is going to tell us your ejection fraction, and it's going to show us the hypertrophy of your heart. So how big your heart is, how enlarged the muscles are. Okay. They're also going to put you on a stress test. We can put you on a treadmill, put you on an EKG. Stop your heart medications before you put them on the stress test. We want to see their heart function the way it's supposed to be functioning, not the way it functions when it's on beta blockers, right? So we're going to put you on an EKG, and we're going to have you walk on that treadmill, and we're going to see if you develop a STEMI or if you develop a ST depression, right? Sorry, not a STEMI, ST elevation or a ST depression. Okay, we're going to look and we're going to see how your heart functions under stress. The ejection fraction, so that's how much blood is leaving in comparison to how much blood is entering, right? So ejection fraction, that's going to be typically between 50 and 75, or sorry, 50 and 70% is normal. So if your ejection fraction is super low, that's going to tell us you're in heart failure. Okay, your heart isn't working the way that it should. Your heart is now failing. Same thing with your hypertrophy of the heart. So the heart is going to hypertrophy. Let's say I had hypertension for 20 years. Okay, I've had hypertension chronically for the last 20 years, untreated, unmedicated. What's going to happen is your heart's been beating so hard to try and meet the demand of your body. Eventually, that muscle is going to grow. And when it grows, it's not like other muscles when they become better when they grow. It's going to grow and it's become less efficient, right? It's too big. Your heart muscle is too big. Those ventricular walls are thick. Okay, they can't serve the function that they were meant to do. Okay, and then you're going to do an angiogram. So it's going to visualize the blood vessels with contrast. Okay, it's more accurate and more common way to diagnose the problem. Okay, there's a 98% accuracy for this. So angiogram. So this is when they're going to take the dye and they're going to inject it into your blood vessels, and they're going to see, is there an occlusion? Okay, uh, so that's what they're going to take a look at. Okay. Keep in mind this dye is very heavy on your kidneys, uh, so you don't want to send them into kidney failure. Okay, so be careful with medication interactions regarding your angiograms. Okay, let's see. So this is going to take us to the cardiac cath labs, right? So cardiac catheterization. It's going to show us, and the angiography. The angiography we said is going to show us the blockages. So it's a diagnostic, and then so this is a two-in-one scenario, right? You're going to go in for surgery. You came in with your chest pain. They're going to say, okay, we're going to take you to cath lab. We're going to do the angiography. We're going to inject the dye into your vessels. We're going to see if you have an occlusion. If there is an occlusion, we're just going to, since we're already there, right? We're already inside. We're going to go inside and we're going to begin our interventions, right? We're going to open the blockages. So you're going to have the PCI, which is the angioplasty. So that's the percutaneous coronary intervention. Then they're going to do the balloon, or they might do the balloon or the stent. Okay, so let's see. Well, we already know that the whiteboard is useless. So the balloon, right? So they're going to go ahead and let's say there is here's your artery. Okay, we have our blockage right here, right? What I'm going to do is I'm going to insert my balloon right here. I'm going to inflate it. So when I inflate my balloon, it's going to open up that artery. It's going to push my plaque down, open up my artery. While the balloon is still inflated, a second arm comes out of my extension, and it's going to put my stent. And then I can deflate my balloon and retract it. Okay, so now I have this stent that's now opening forcing my artery open. Okay, some of these stents even come laced with medications, so anti-platelet platelet medication that's going to prevent further clotting of your blood. Okay, so that's balloon angioplasty in your stent. Okay, so afterwards, so our nursing interventions, caring for our patients after they've gone through this procedure, we're going to monitor for signs of recurrent angina. So we're going to put them on a cardiac monitor, frequent assessment. A frequent assessment. So we're gonna check their temperature, their cap refill. their heart rhythm, right? Level of consciousness. A lot of this is going to revolve around preventing bleeding. Okay, so remember, lay them flat. A lot of times they used to go in through the femoral artery. Now they can go in through radial, right? So prevent bleeding. Um, Neurovascular assessment, check for stroke, maintenance of bed rest, right? Keep pressure on that wound. We don't want them to bleed out. Um, Discharge teaching, so diet and exercise. If there are new medications, reduce cholesterol. They should never change a tire or shovel snow. So heavy lifting and bearing down, they could rupture whatever we did to fix them, right? So these bearing down exercises, right? How long to wait to have sex? After you can fly, after you can fly, after you can climb 2 flights of stairs without chest pain or shortness of breath, you can go ahead and have sex. Remember, sex is cardio. Um, so that's that, right? I mean, pretty realistic. Um, Unstable angina, right? So this is going back to you have pain even when you're resting. Remember, this is something that's more severe, right? So even when I'm resting, that means my oxygen supply is lower than the demand, and I have a ruptured clot, right? So again, chest pain, new onset, occurs at rest, longer than 10 minutes, yada yada yada. This one needs to be treated promptly, right? So call 911, get yourself to the hospital. Um, could be acute coronary syndrome, so STEMI and STEMI. The STEMI, so ST elevated myocardial infarction, right? So this is an occlusive thrombus and it's an emergency, right? If I have a STEMI, that means my ST elevation that we talked about earlier is already up. Remember when your tissue dies and it goes to heaven? Okay, ST elevation, right? So we already have necrotic tissue, right? Because we don't have any oxygen. So we got to get that EKG on within 10 minutes. Okay. Our problem is we have no oxygen. So from the field to the needle, we're going to do TPA within 30 minutes, but it doesn't have priority over cath lab. Okay. So from the field to the cath lab within 90 minutes. Okay. Watch for bleeding and do your neuro assessment. So our goal, we only have 90 minutes to treat STEMI. So 90 minutes, your goal is to get them to that cath lab as soon as possible, see the problem, diagnose it, do your stent and balloon. Okay, that's what we're going to do to treat that heart attack. Now you have a little more time with NSTEMI. You have close to 24 hours because it's non-occlusive, right? Our thrombus isn't fully taking up that artery, right? And it's non-STEMI, right? Which is there is no ST elevation. Okay, no ST elevation is good. That's good. We don't want ST elevation. They're going to check your biomarkers. Okay. So um, you're going to have, if there's low biomarker, so negative biomarker, it's an old MI. Okay. So you had a MI. Okay. If it's positive, then you currently have an MI. It's new. Okay. Let's talk about acute coronary syndrome, ACS. So it's ischemia with myocardial cell death, okay? Imbalance of oxygen supply and demand, same story as we've been talking about. Um, it can be caused by atherosclerosis, embolisms, blunt trauma, and spasms, right? And back to our EKG, how to set it up. I remember this, how I remember it. We read from left to right. Okay. The left side of the body, you have smoke over fire. Right side, you have snow over grass. Okay. We read from left to right. That's how you know. Smoke over fire, snow over grass. And you like your sweets with chocolate in the middle. So the middle is brown. Okay. So you read from left to right. Smoke, fire, snow, grass, chocolate in the middle. Okay. Let's see. Okay, so if you have angina in acute care, position the patient upright, give them supplemental O2, assess your client right, place them on a continuous EKG, the 12 lead, provide prompt pain relief. So first we're going to go with nitro, right? So MONA, so morphine, oxygen, nitro, aspirin is old, right? Remember MONA is old. So we switch the order around a little bit. So first start with nitro. Uh, excuse me. First start with nitro, okay? Then go to oxygen, so oxygen, nitro, morphine, and then our antiplatelet, and morphine is going to be last. Okay, so 162 to 300 milligrams of chewable, so baby aspirin, um, is going to be sufficient. Get their biomarkers, assess the heart and breath sounds, get their chest x-ray, all that good stuff. Okay, remember pain, oxygen, and EKG before biomarker. Okay. Let's see. So signs and symptoms of MI. We should know this already. Abdominal pain, so chest pain, radiates to the shoulder, tachycardia, sweating, anxiety, impending feeling of doom, jaw pain, right? Let's see. So the keywords are going to be things that are sudden, crushing, radiating. That pain radiates to the left side, radiates to the jaw, heavy pressure. All of these are indications, right? Keywords. Let's see. Troponin. What's our troponin level? So troponin is going to be greater than 0.5. That's going to tell you that there's muscle injury. What muscle are we looking at? We're looking at the heart, right? So that's going to tell us MI. So troponin T stays for longer, so 7 to 10 days. Troponin I is being released within the first 6 to 8. CKMB, very rapid. It's going to last 4 hours. And then myoglobin, right? So we're focusing on that troponin greater than 0.5. 0.5 magic number. Okay. Complications of MI, you have the dysrhythmias, so VTAC, VFib, those are the only shockable rhythms. Then you have heart failure, acute heart failure, cardiogenic shock, your heart's not pumping up enough blood for the rest of the volume, enough blood volume for the rest of the body, you go into shock. Pericarditis, you have friction rub, all that good stuff. So treatment for MI, cardiac cath, thrombolytic therapy, drug therapy, CABG, coronary artery bypass, oxygen, nitro, aspirin, morphine. Oxygen, nitro, aspirin, morphine. It's not MONA, it's ONAM. Okay. Let's see. All right. Now on to the fun stuff. Heart failure. Real exciting. So there's several types of heart failure. Everything has several types. We're crazy around here. So chronic heart failure, categorized as a progressive worsening of ventricular function and chronic neurohormonal activation that results in ventricular remodeling. That's a whole lot of words for saying your ventricles suck, right? So the ventricles are responsible for pumping blood. Specifically, your left ventricle is going to be pumping that oxygenated blood to the rest of the body, right? Right ventricle is going to take the deoxygenated blood to the lungs. They get oxygenated. They come to the left atrium, drops at left ventricle, rest of the body. Cool. The ventricles over time are going to evolve in shape, right? Let's go back to the example I used a while back, right? You have long history of hypertension. Your heart is going to, over time, overwork itself. You're going to have that thick left ventricular wall because it's been pumping so hard your entire life. And over time, that thick ventricle is going to be not efficient, right? You're going to have that heart failure. So this process involves changing in size, shape, mechanical performance of the ventricle, right? Uh, So your heart failure with preserved ejection fracture and heart failure with reduced ejection fracture. So you're going to have two types, right? So one is going to keep your ejection fracture normal. Remember, we said ejection fracture was diagnosed with your echocardiogram, right? And they're seeing how much blood is leaving compared to how much blood is entering the heart. Ejection fracture should be 50 to 75, right? That range. Dips below that, then you have reduced ejection fracture heart failure. Okay. So let's see. This is going to tie back. Remember in class we talked about the RAS system. So your body senses that in the baroreceptors, right? Your body senses that the blood pressure is low. Okay, it's going to start. It's going to ignite the RAS system. So renin, angiotensin, aldosterone system. Okay, so it's going to tell your kidneys, hey, let's get this process up and running. Let's increase that blood pressure. And this is it's something that happens very chronically, right? So it's going to increase sodium, NaCl absorption, so sodium chloride reabsorption, and it's going to vasoconstrict to improve cardiac output. Remember, these small adaptations, so like the RAS system, increasing heart rate, these are supposed to be short-term fixes. Your body does these to fix the situation short term. Over time, these get out of hand, and that's when you get stuff like heart failure. It's going to increase in muscle mass and cardiac wall thickness. It's progressive. It takes time for these changes to increase muscle tissue, and initially it works. These adaptations work for quite a long time before it leads to heart failure. Okay. The issue with wall thickness, the ventricular wall thickness, is those muscles also, the new muscle also needs oxygen, and now you just don't have any. Okay, you're gonna get these dysrhythmias, you're gonna get ischemia, right? They're compensatory mechanisms, right? So enlarged chamber of the heart that it occurs with pressure in the left ventricle is initially effective. Okay. Let's see. So what happens when your ventricles stretch out, right? So when that stretch is there, it's gonna elevate a chemical called BNP. Okay, so BNP is going to be released when these ventricles, these muscles are being stretched to their limit, right? The BNP, you're going to measure it, and a elevated BNP is going to tell you that there is muscular damage, and that's going to be something that you can look at even before you have an echo. You look at your elevated BNP levels, and you can say, well, we're suspecting heart failure, right? Let's see. So we have left-sided heart failure, right-sided heart failure. Eventually, you're going to get eventually you're going to get both. Okay. So I like to think of it as a traffic jam. This is the distinguishing factor between left and right-sided heart failure. You're going to need to know your anatomy of the heart. So the left and the right side, right? So if I'm on a freeway, right, and here's my freeway, and I have the accident here, traffic is flowing this way. I have the accident here. The traffic jam is going to back up this way, right? That's what logic tells us. If I have the accident here, traffic is going this way. The cars are going to be backed up this way, okay? Same thing happens with heart failure. So the blood comes in through the vena cavas, right? They enter the right side of the heart. This is deoxygenated blood, enters the vena cavas, goes into the right atrium, right ventricle, goes to the lungs. They become oxygenated, come back, left atrium, left ventricle, which pumps oxygenated blood to the rest of the body. Okay, got that? Cool. So the traffic jam is going to happen at the right side. Okay, right-sided heart failure. Okay, now this deoxygenated blood, which is coming from the rest of the body, coming from the top half, bottom half of your body, is now going to be stuck in your vena cava, stuck in your right atrium, stuck in your right ventricle, because now your right ventricle is struggling. So where's the traffic jam happening? Okay. Is it going to happen on the left side? No. Is it going to happen in the lungs? No, because the blood hasn't gotten there yet. Okay. So our blood is now backed up in the rest of the body. It's going to be backed up in the rest of the system. Okay. I have now edema. I'm going to see edema in my lower extremities, right? That blood that's backed up in my vena cava. I'm going to have that swelling, that water in my lower extremities, that pitting edema. I'm also going to have that edema in my JVD, right? I'm going to have a development of JVD. Okay. Um, it's going to also increase nocturia. This is your peeing in the middle of the night. Why is this happening, right? I have all of this fluid that's backed up in my body. Okay. A lot of times we make the mistake of looking at these diseases as if it's somebody in a lab, but we forget that these people also have to go about their lives, right? This person is going to go to sleep, they're going to lay down flat in their bed, and then they're going to wake up and they're like, I really have to pee. Why is that? So all that fluid is now backed up in their body. I have fluid in my legs. I have the JVD. I have all that good stuff. And I'm laying down. That water is going to go down, right? Gravity is going to act on that water and I'm going to have to urinate, right? I'm going to have to go use the bathroom, right? So right heart failure is going to give you nocturia. It's going to give you chest pain, elevated liver enzyme. Now, why am I going to get elevated liver enzyme? Remember, the inferior vena cava, the lower vena cava, is going to take deoxygenated blood from the lower half of your body, right? This includes your liver, this includes your GI system, this includes your legs. Okay, now I have all this fluid, all this extra blood is backed up in those areas. So I have all this blood, all this fluid that's now leaking interstitially into my cavities, and it's pressing down on my liver. It's pressing down on my stomach. It's pressing down on my gastrointestinal system. So I have ascites, right? So ascites is that fluid in your stomach. If you remember back in physical assessment, you do the shifting dullness test where you lean to one side and you'd go ahead and you tap and it's dull because it's all filled with fluid, right? So all this fluid is now weighing down on my liver, right? Um, and it's causing damage. So elevated liver enzyme and anorexia, right? If I have fluid pushing on my stomach, I'm going to feel full. So I'm not going to want to eat, right? Remember, anorexia isn't the mental disorder in this case. It's the loss of appetite. Okay. So GI distress, weight loss. Why am I going to have weight loss? It's from food, right? I'm going to have weight gain in terms of fluid. Okay. But I have anorexia. I have fluid pushing on my stomach. I feel full all the time. I have no appetite. Okay. So you're going to have JVD and sudden weight gain. So that's 3 pounds of weight gain in 2 days or 5 pounds in 1 week. Okay. So that's a sign of heart failure. Okay. So remember, that's 3 pounds or greater in 2 days. Okay. Um, and they're going to take a look at your BNP. They're going to take a look at your echo, chest X-ray, stress test, all that good stuff. Okay. Now let's look at our left-sided heart failure. So now your left ventricle, whose job is to pump oxygenated blood to the rest of the body. So this blood is oxygenated, which means it came from where? Came from the lungs, right? All this blood just came from the lungs, and it's now in the left ventricle, but our left ventricle sucks, right? So where's all this blood going to back up? Into the lungs, right? So now I have all this extra fluid in my lungs. I have that productive cough, that constant cough. I can't breathe as well. I have that shortness of breath, dyspnea. I have tachycardia. The froth has froth. That cough has frothy sputum, weak pulses, fatigue, orthopnea. I can't get a sentence out without needing to catch my breath. Um, I need to sit down, seated up. If I lay down, I can't breathe. Why is that, right? So if I'm laying all the way down, I have all that fluid now pressing down on my lungs and I can't breathe. Okay? So you have that orthopnea. Okay? So that's left-sided versus right-sided. At the end of the day, if I have left or right-sided for long enough, I'm going to end up with both. Okay, you're going to end up with both, but it's good to distinguish one or the other and know the core problem between left and right. Okay. My key to remembering left and right heart failure, just know your anatomy. Just know left and lung. Okay. Left ventricle comes from the lung. You're going to have your lung problems, fatigue, dyspnea, orthopnea, all that good stuff. Right-sided heart failure, you need to look at the whole situation. Look at your superior vena cava, which leads, your inferior vena cava. Think of your JVD, your edema, that pressure on your GI. Okay. Uh, let's see. So these B-type natriuretic peptides, so BNP, is going to be released from the ventricle. Let's see. So what drugs are we going to give? So remember, a lot of these problems are revolving around the accumulation of fluid, right? So we're going to give a loop diuretic. So this is going to be your Lasix. Okay, Lasix is the most common. It can be given PO, IV. Lasix is going to be given. We don't want all that fluid hanging around. Then they're going to give your ACE inhibitor. Remember, your ACE inhibitor is going to stop that RAS system, okay? And so is your angiotensin meds, okay? Your angiotensin 2 blockers. So ACE is the first line of defense. Your ACE is your prill medication. Remember, lisinopril, all that good stuff. A long-term cause of being on these ACE inhibitors is your client might develop the prill cough, which is just a cough that's associated with being on these medications. So if your ACE inhibitor doesn't work, they're going to move you to an angiotensin 2 blocker, so your sartan meds like losartan. Okay, these are going to block angiotensin. Remember, angiotensin 1 is converted into angiotensin 2, and then that's what continues the RAS system. It's going to stop angiotensin 1 from becoming angiotensin 2. Okay, so these are your angiotensin 2 blockers, your losartan. And then they're going to give you your vasodilators again. Remember your nitro, right? Nitro is used a lot for cardiac, just because we want to dilate your veins. We want to make it easier for your heart to pump out all that blood. Okay, and then your beta blockers. We didn't forget about those. Remember, beta is your LOLs, your beta blockers, so your atenolol and metoprolol. Okay, remember beta blocker. We've got to look out for the heart. These meds are going to affect the heart. Okay. And remember, for asthma, for those beta blockers, you're going to have the positive inotropics, so that's going to increase contractility and decrease heart rate. So remember, watch out for asthma if you're giving your beta blockers. We don't want it to interfere with the lungs. We want cardio specific. Okay. Also, digoxin. So digoxin is going to increase contractility of the heart. It's going to squeeze on those ventricles, make them push out blood harder and faster, meeting the supply of the body more adequately, right? The digoxin is toxic, right? That's something you have to look out for. So digoxin toxicity, our range is from 0.8 to 2.0. Okay. Anything greater than that is toxicity. Lower than that, it's not in the therapeutic range. It's not going to function as good. Monitor for potassium. Right, remember potassium 3.5 to 5 affects the heart rate. Monitor apical pulse for 1 minute. What are signs of digoxin toxicity? You have the green halos, visual disturbances, nausea, vomiting, anorexia, all that good stuff. Okay. So digoxin is good, increases the contractility of the heart, but it is toxic. Okay. Um, so let's see. All this stuff is going to relate to impaired gas exchange, um, impaired perfusion, all that good stuff. Let me look through my notes. Remember, if they have these issues, we want them on low sodium, no salt, right? DASH, dietary approach to stopping hypertension. Daily weights, 3 pounds in 2 to 3 days, 5 pounds in a week. Maintain activity as tolerated. All that good stuff. All right, now let's talk about our final topic, which is thrombocytopenia. Okay, so thrombocytopenia, so the death of the platelets um, all throughout your body. Okay, so we have three types. Let's start with the first one, which is immune thrombocytopenic purpura. This used to be idiopathic, right? We used to not know what caused this. We used to think it just happened spontaneously. Turns out your immune system starts to target its own platelets and it starts killing them systemically, right? So the death of the thrombocytes ends up giving you this purpura, the small rash like bruises on the skin. Typically in autoimmune infections, so people with HIV, hepatitis, and H. pylori, right? H. pylori is the bacterial infection that gives you stomach ulcers. So if you have an H. pylori infection, one of the sequelae of that can be immune thrombocytopenic purpura. Okay, so if it looks like HIV, hepatitis, and H. pylori, triple H, right? You have triple H, you're going to get immunothrombocytic purpura. All of these infections weaken your immune system. Okay, they screw up your immune system and it starts to target its own platelets. So clinical manifestations, it's going to include bruising really easily, petechia, bleeding from orifices like your gums, your nose. It can even manifest with GI bleeds. It can cause brain bleeds, and that's life-threatening, right? So think about it. All of these thrombocytic conditions are going to increase your chance of bleeding, right? We lose our ability to clot. So that bruising underneath the skin is from blood leaking out underneath the skin. It looks like a bruise. Okay. Bleeding from your nose. You blow your nose too hard, you're going to have a bloody nose, right? You brush your teeth, you floss, you're going to get the bloody gums, right? Um, Again, this is the more severe cases in GI and brain bleed. Uh, so how do they diagnose this? It's diagnosed after other causes of thrombocytopenia are ruled out. So they'll take the CBC, they'll say, okay, maybe you have cancer or something else that's causing your platelets to die off. And then after they've ruled everything out, then they see that you've had one of these infections in the past, and they'll say, okay, then maybe it's immune thrombocytic purpura. Okay, um, so they'll do a CBC or a peripheral blood smear, and they're going to use that for their diagnosis. So you're going to use a hematologist to treat this. These interventions, right? Look at the problem. What's the problem? Our immune system is fighting our blood. How do we get rid of it? We're going to weaken our immune system further. Corticosteroids, immunoglobulins, and thromboprotein receptor agonists, right? In severe cases, they're going to take out your spleen. While your spleen, the spleen is in charge of, it's kind of like the graveyard for your white blood cells, right? So they're going to take that out and they're going to see if it changes. So remember, corticosteroids, they're going to try to weaken your immune system, okay? If last case option is going to be splenectomy, we're going to go from least invasive to most invasive, okay? That's immune thrombocytic purpura. It's in the name. Okay. Now let's talk about thrombotic thrombocytic purpura, TTP. Okay. I have a story to go along with TTP. Actually, uh, yeah, we'll stick to one story per condition. Okay. So TTP, bear with me. Adam had this friend named Vaughn. Okay. Uh, So Adam's dream, no, actually, I'm getting this mixed up. So Vaughn's dream is to be famous. Okay. He's working his whole life to be famous. His friend Adam is a hater. He hates on Vaughn. He doesn't want him to succeed, doesn't want him to become famous. And his whole job is whenever Vaughn gets too big, Adam comes around and he knocks him down. One way or another, he knocks Vaughn down so he can't become famous. Okay. Now, one day, Adam is sick. Okay. He's not able to be a professional hater. So, what does Vaughn do? Vaughn does his thing. He gets famous. Okay. All of his fans crowd the area and they come to meet Vaughn. Okay. and Adam can't do anything to stop it this time. Okay. Now, why is this the story? Well, let's put it into context of the disease. So thrombotic thrombocytic purpura. Okay. In your body, you have von Willebrand factor that's in charge of clotting. Okay. And you have this enzyme called ADAM TS13, ADAM TS13. Just like the story, Von is made for clotting. Think of him as a protein in the blood, and he goes around whenever you have a bleed, and he hangs on to that wound, and he catches as many platelets as he can, and he clots that wound. Okay, so Vaughn goes around and he does his clotting job. He grabs onto platelets and he packs that wound until it stops bleeding, which is very good when we are bleeding. Okay, now why is Adam the hater? Why does Adam keep cutting up Vaughn? Well, when von Willebrand factor, VWF, gets too out of hand, the clotting also gets out of hand, right? He grabs all of these platelets, it becomes a huge traffic jam, and you have this huge clot that forms in your body. So what's Adam's job? Adam walks around, and when these von Willebrand factor are no longer needed, or if they're too big, Adam is the enzyme that breaks down VWF. Okay. In a normal functioning body, they have this relationship where if the VWF gets too big or gets out of hand, the ADAM TS13 enzyme comes around and it breaks down the VWF so you don't have a huge clot. You only need enough VWF to stop your bleeding. Okay. In this condition, the ADAM enzyme isn't around. Okay. It's not around as much or it's completely gone. So VWF is left to run around unchecked. And what it's going to do is it's going to clot up in certain areas of your body. These clots are going to form and it's going to use up all of your platelets. Okay? Platelets are used to create these clots. So I'm going to pull all of the platelets to one side of the body. I'm going to create a blood clot and you're going to spontaneously start bleeding from other parts of your body, right? Remember, like your nosebleed, your gums, all that good stuff, because you no longer have any clotting factor left. This is going to simultaneously overclot and underclot at the same time. Okay? So, this condition results in clotting throughout the body, such as neurological defects due to limited blood flow to the brain, to the kidney, dysfunction due to poor kidney perfusion, fever, pallor, and purpura. Okay, why are we getting purpura if purpura is bleeding? Remember, we used up all of our clotting factor. Now we are unable to create clots where we need. We're going to bleed under the skin, and that's going to give you that purpura. Okay. So this is going to have a significant drop in platelet count, usually greater than 50% from the baseline, recurring 5 to 10, or sorry, I'm reading too far ahead of my notes. That's for heparin induced, which we'll get to in a sec. So ADAM activity is critical for the diagnosis. They'll do a CBC peripheral smear. Renal function tests are also important. Okay, so that's how they diagnose it. Management. Oh, so sorry. Management usually requires hematologist. For this, they'll do a plasma exchange. That's the main treatment, along with corticosteroids. Okay, and they'll give you caplazizumab, which is an anti-VWF. Okay, so plasma. They're gonna give you plasma. Okay, so this is my favorite of the thrombocytopenias because it has a little story. All right, remember this is going to simultaneously overclot and underclot at the same time because of a lack of your ADAM enzyme. So they're going to give you plasma, and hopefully that's going to treat it. Okay. Moving on, we have heparin-induced thrombocytopenia. Okay, as it sounds, this is heparin-induced. Okay, so it's an immune-mediated adverse reaction to heparin. it's going to form antibodies against complexes of platelet factor, which is called PF4, and heparin, leading to platelet activation. Okay, what does all that mean? So in the normal body, right, you have the antibodies, you have PF4, and you have heparin. Okay, what happens in this case is all of these combine together to create something new. Okay, so the heparin, the PF4, and the antibodies all combine together to create something that's bad for your body. Okay, the combination of antibodies to the heparin and the PF4 complex results in an increase in blood clots despite being on heparin, right? So this is going to give you an inverse relationship. So I'm going to give you heparin expecting blood thinner, which is an anticoagulant, and I'm going to end up with more blood clots than when we started, right? So this combination of factors in your body is going to increase the clotting factor. Now, luckily, since this is chemically induced, the solution is quite simple, right? It's kind of like an allergic reaction. The first step is to take the allergen away. Okay? If you're allergic to peanut butter, I'm not going to give you more peanut butter. I'm going to take it away from you, right? I'm going to stop the exposure. So step number one, stop the heparin, okay? If I can. If it's heparin IV, we're going to stop heparin exposure, okay? When does this manifest? So it's going to be that significant drop in platelet count, which is greater than 50%, after 5 to 10 days after heparin exposure. So I'm going to give you heparin. 5 to 10 days later, you're going to have a 50% or greater reduction in platelets. Okay? You're going to start losing your clotting factor. You're going to lose your clotting factor 5 to 10 days after heparin exposure. It's going to lead to thrombosis, which can be life-threatening. So the reason for the drop in platelets is because they're being used on a large scale to create blood clots due to this condition leaving systemic shortage of platelets. So same thing like the atom, like the thrombocytopenia. You're having too many blood clots that are caused by the heparin and the PF4 combination, that you no longer have any active clotting factor anywhere else. Okay, so this and the one before it both manifest in the same way. You have blood clots somewhere and you're bleeding somewhere else. Okay, so sorry. So the diagnosis is based on the clinical assessment and lab tests. And obviously, if we gave you heparin and you developed this condition, that's what we're going to be suspecting. Okay. They're going to treat it. They're going to switch you off of heparin. They might put you on warfarin, but most likely they're going to stop your heparin, right? So they can put you on other anticoagulants like argatroban or bilirubin or warfarin, right? Once your platelet count stabilizes. And that's a quick little recap of your ITP, TTP, and HIT, right? Remember, one is immuno, which is after an infection, right? One is caused by a decrease in atom, right? And one is caused by heparin. They're kind of all self-explanatory in the names, right? And that should be it for this chapter. Feel free to go ahead and look at questions from the book, questions from the ATI, but that's all of the information that I've managed to gather about this chapter.